In a way, obviously, what we do is personalization. I think the first step in personalization really is the disease risk assessment. And we've been trying to look at this and look at the natural history of lower risk MDS. What happens to those patients? And obviously, there is a subset of patients that will progress to acute myeloid leukemia or higher risk MDS. And there are different patterns in the disease progression actually among those patients. But roughly, probably, 2/3 of the patients will stay as a lower risk. So there are patients that will go to higher risk MDS than AML. There are patients that will go to higher risk MDS and just stay in higher risk MDS. And there are patients, unfortunately, will progress to AML from the get-going. So that's one group of the lower risk. But the majority will stay as a lower risk group. And even with those patients, when we've looked in the past and recently with different risk models, there is still around 25% of those patients that unfortunately will die within a couple of years. And when we look at the cause of mortality, it's still very directly related to the disease and complications of the cytopenias, or indirectly exacerbating some other comorbidities. So I think a key in personalizing the treatment is really identifying the disease risk and us getting better in identifying those patients that either are going to progress or they are going to have less than 2-year survival, because then obviously we will change our thinking or paradigm of just holding the transplant till later on. And those patients will be candidates for allogeneic stem cell transplant. And nowadays we can extend those transplants to age of 75 in patients that are functional with no comorbidities. So if we can identify those patients, I think those patients should be treated as a higher risk. Then obviously personalization is, as we mentioned, nowadays, we select the treatment based on, the cytopenias themselves, the comorbidities for the patients, and factoring, the effect of those cytopenias on the patient, symptoms, quality of life, as well as the interaction or the interplay with the other comorbidities. So as we mentioned, if patients have thrombocytopenia, then we go treating that. If they have neutropenia, we treat that. In the treatment of anemia, I think it is, getting more and more personalized. So deletion 5q has an option of treatment. Patients with ring sideroblasts have an option of treatment. Younger patients have option of immunosuppressive therapy. And I think the next, obviously, is also trying to look at subsets with certain somatic mutations and target those. So, for example, the IDH1, IDH2, can be seen in around 5 to 10% of lower risk MDS patients, and that could be a viable target that we should be testing in clinical trials. So I think we are moving there. Obviously, the more active therapies we get, the more the principle of early intervention will make a difference, maybe changing the natural history of the disease in the future. And as I mentioned, also nowadays, we've recognized this spectrum of clonal hematopoiesis, that there are patients that will have just somatic mutations with no blood count abnormalities. We refer to it as CHIP, clonal hematopoiesis of indeterminate potential. And then there is patients that have cytopenias with mutation, but the bone marrow is not showing the classical dysplastic features or increased blast. We call that clonal cytopenia of unknown significance. And those patients are obviously at risk of progressing to MDS. So some of the effort or personalizing the treatment is moving it also earlier in those patients with, interventions or treatments that hopefully will, prevent or slow the progression of, the pre-MDS, if we can say, to the state of MDS.